جزء من التعاون للجمعية العراقية لأمراض وزرع الكلى وجزء من برنامجها العلمي. نتشرف اليوم بحضور أستاذنا دكتور بسام سعيد، very eminent pediatric nephrologist وأخ وصديق وزميل عزيز، نتشرف كلنا بحضوره معنا. Our moderator for today أستاذ الدكتور عمار عبد اللطيف، consultant pediatric nephrologist, head of pediatric nephrology education program in Iraq, and he will present Professor Bassam Saeed, and then we will start the presentation. Go ahead دكتور عمار.
السلام عليكم جميعا. أحب أرحب بجميع الأخوة المنضمين إلينا. الأستاذ الدكتور بسام سعيد، السلام عليكم ورحمة الله. طبعا الأستاذ الدكتور بسام سعيد اليوم راح يكون ضيفنا، راح يقدم لنا محاضرة بعنوان Approaching a Child with Hematuria. كنا نعرف بالحقيقة أستاذ بسام هو غني عن التعريف. أستاذ بسام Professor and Consultant Pediatric Nephrologist at Farah Association for Children in Syria. He has very prominent achievement in the field of pediatric nephrology and transplantation in Syria and Middle East. He is the immediate past president of the Middle East Society of Organ Transplantation. He has many publications in well-known journals. أهلا وسهلا أستاذ بسام. The floor for you, please.
Thank you very much. Thank you very much. First of all, I would like to thank all our friends from the Iraqi Society of Nephrology and Transplantation, Professor Safa Mukhtar, Professor علاء الشيخ علي، وشكري للجميع الموجودين حاليا، وطبعا شكري يمتد لرئيس الجمعية العراقية الصديق العزيز علي الساعدي. I'm very honored and pleased to be your guest today, talking about a very important topic, approaching a child with hematuria. We can start now. Can we start, friend?
Yes, sir. Yes.
Yes. Okay. So this is the outline of my presentation for today. First of all, we'll look at the visual examination and microscopic examination. Then we'll move to persistent isolated microscopic hematuria, then macroscopic hematuria and how to approach hematuria. And then we will go through certain very important diseases that gives hematuria, like Alport syndrome, familial benign hematuria, and acute post-streptococcal glomerulonephritis and IgA nephropathy. What about visual examination? First of all, we have to distinguish between true and false hematuria. True hematuria, we have to distinguish between real blood or something else of red color. So bright red is indicative of heavy bleeding. Brown urine indicative of hematuria, could be overnight or etc. Or hemoglobinuria or myoglobinuria. So bright red is always heavy bleeding, but brown urine could be something else like hemoglobin or like myoglobin. Now, false hematuria, any red discoloration of urine, whether it is related to food, drugs, or very rarely to inborn error of metabolism. So not any red urine is hematuria. Also, we have the urate crystals, which is somehow common in infant and small infant, which gives pinkish nappies. Quite often we see ladies bringing their newborn of a few days old. They are very anxious just because the napkin, the diaper is of pinkish color. First of all, at that period of time, especially the first week of life, we have to think of this urate crystal in the urine because it gives the same color, but it is not a blood. So it is part of the false hematuria. And factitious hematuria, we have always to keep it in mind. Now, what are the causes of misleading dipsticks test for hematuria? It could be false positive or false negative. False positive result is related to oxidizing agents, while false negative is related to reducing agents. So this is something related to the lab. When the lab is putting something oxidizing or reducing, this may change the result completely and give us some misleading, whether false positive or false negative. And at the same time, although it is not related to hematuria itself, but it is very important, which is the misleading dipsticks test for proteinuria. There are many reasons behind the false positive results. When we do dipstick, we see 1 positive or 2 positive or 3 positive, especially when the urine is too much concentrated, highly concentrated urine, or alkaline urine, gross hematuria. Quite often we see with it protein, 1+ or 2+. In fact, there is no protein with it, but just because there is gross hematuria, we'll see 1 or 2+ false positive result. Pyuria, bacteriuria, or when the dipstick was left in urine too long. So we shouldn't keep the dipstick in the urine for a long time. Or the delay in reading dipstick, or when it is contaminated with drugs. All this reason can give us false positive protein. On the opposite, false negative result can be the result of very dilute urine or acidic urine or non-albumin proteinuria, especially in children when they do have some tubulopathy. We do have here at that time non-albumin proteinuria. So the patient is having proteinuria but not albuminuria. But when the dipstick itself, it tests the presence of albumin, although we call it protein, but in fact the dipstick is looking for albumin. So if there is no albumin, it gives us there is no protein, while in fact there is tubular origin proteinuria. Now the microscopic examination, the definition differs between references. In fact, most of them, they define proteinuria when red cells exceeds 5 cells. Other references, they say when it exceeds 3 cells. Anyway, it's between 3 to 5. We have to concentrate on morphology, and we'll tell you why in a few minutes. The morphology of RBCs in urine is of extreme importance. And we need for this purpose phase contrast microscope. So phase contrast microscope and polarized light microscope are very useful tool in our lab. So the erythrocyte in the urine, there are 2 main types, glomerular and non-glomerular origin. When the RBCs are of glomerular origin, the morphology of these RBCs, usually they are dysmorphic because they pass through the glomerular basement membrane, so they will be dysmorphic. And when the RBCs are of interstitial origin or of urinary tract origin, so it is not glomerular, the RBCs will be isomorphic, normal, or oomorphic. This is an example of the glomerular or dysmorphic erythrocyte. We can see very clearly that the RBC is really very dysmorphic, very irregular, comparing to non-glomerular erythrocyte or isomorphic. You see here the RBCs are very regular, so we call it isomorphic, or we call it oomorphic. So isomorphic means non-glomerular, dysmorphic means glomerular. And this is very important in our practice because when it is glomerular, we think of glomerular origin protein, hematuria, means glomerulonephritis, etc. While when it is non-glomerular, the patient may not need biopsy, need urologic investigation. So this here I'm referring to one old study. It maybe a little bit less than 40 years ago. It was published in Kidney International. It talks about a simple method for identifying glomerular bleeding. In that study, which is very interesting, they looked at 2 categories of patients, patients with glomerulonephritis and patients with urologic disorders. Look here for patients with glomerulonephritis, for example. They noticed that out of 58 patients, none of them had isomorphic RBCs. 55 of them out of 58, means almost 95% of them, the RBCs were dysmorphic. So 85%, 95% of patients with glomerulonephritis had dysmorphic RBCs. The opposite is true for patients with urologic disorders, because here they noticed that out of 30 patients, 0 patients had dysmorphic RBCs. 30 out of 30, so all of them, they had isomorphic RBCs in the urine. So urologic disorders gives isomorphic RBCs. Glomerular origin hematuria give dysmorphic RBCs. It was very important because from that time, from 1982, we knew from that time that detection of glomerular bleeding by phase contrast microscope, because phase contrast microscope will tell us more about the morphology of RBCs. If we don't have this phase contrast microscope, it will be much difficult to distinguish between oomorphic and dysmorphic RBCs. And but we need cutoff. Of course, we will not see 100% or 0%. We need cutoff. So it was settled that 80% is probably the best cutoff. Of course, in the literature, you may find some different cutoff. And this is one of the problems that we are facing today, is to have some fixed cutoff. Now, the definition of hematuria as glomerular or non-glomerular in this study, which was published in The Lancet in 1982, it was said at that time that if the dysmorphic RBCs exceeds 80%, this means that this hematuria is of glomerular origin. If it is below 80%, it is unlikely to be glomerular. So, as I said before, there are certain problems associated with this analysis of urinary red cell morphology. First of all, it requires experience. Not any lab can do it for us. That's why when we look at the morphology, we have to contact some lab that we know already that they do have experience with analysis of urinary RC morphology or red cell morphology. Then the other problem is that this test is exposed to the risk of low inter-observer reproducibility, which means that if we have the same urine sample, we divide it in two, and we send it to 2 labs in the same time, we may have 2 different results from the same urine sample, which means that it is it is of low reproducibility. That's why we have to depend on one lab that we know already that this lab is having lots of experience with this matter. The other problem related to this RBC's morphology is that we still lack universal criteria for defining hematuria as glomerular or non-glomerular. Few slides before, I said that the cutoff is 80%. Well, for other references, you may see 60% or some other figure. Well, that's the reason why we don't have univocal criteria for defining hematuria as glomerular or non-glomerular. But when we do have acanthocyturia, we are in a more comfortable situation. Why? Because acanthocyturia, we will talk about it, and we will see it next slide. It is a subtype of dysmorphic RBCs. It is one of the characteristic marker for glomerular bleeding. So when we see acanthocyte like this, for example, but this is by scanning electron microscope, it is very, very dysmorphic. Okay, here we can see it by phase contrast microscope. You see the RBCs is very extremely dysmorphic. If we call it acanthocyte. So if we see this acanthocyte exceeding 5%, that is enough to say with certain trust that this is of glomerular origin. So the presence of acanthocyte is very sensitive and very specific for glomerular bleeding than other dysmorphic cells. Now, the question that comes to mind quite often when we handle a patient with persistent isolated microscopic hematuria, whom shall follow this patient, nephrologist or urologist? Well, you know, this discussion will continue, I think, for a long time, and we may never reach a solution or a clear answer for that. But being a nephrologist, being a nephrologist, I would say that nephrologist should see the case. And if the nephrologist suspected some urologic problem, then at that time, we may refer the patient to urologist. Probably I am a bit biased by this because I'm nephrologist. Anyway, now look at this. This is erythrocyte cast. This is very pathognomonic of glomerular bleeding. When we see it, but unfortunately, it is rarely seen. When we see, because it is a cast, so no one can discuss. The cast means it is coming from the kidney. This erythrocyte cast, as you can see here, it cast full of RBCs. But the problem is when we sediment the urine, it will be dissolved because it is cast and it is very fragile. Now, as I said before, we need a proper microscope in our lab. In our lab, when we examine urine, urine is very important. We know because many people consider urine as liquid biopsy. So when we examine urine, it is a sample from the kidney. So we need to have all the tools that allow us to better look at this urine. We need, for example, this phase contrast electroscope and polarized light. Polarized light, especially for cast, but when it comes to phase contrast microscope, it is the better way to appreciate and better see the particles against the background. Look here, for example, the particles are much better seen against the background compared to this one. This is not a phase contrast microscope. As you can see, if you do the comparison between these two pictures, it is very clear that here in phase contrast microscope, we can see the border of the particles against the background very clearly. One thing also very important, which is a proper report. Proper report from the lab doctor or lab technician or lab people. We need a proper report. You know, sometimes the laboratory are not giving much attention and to urine examination because they do have every day, I don't know how many samples, so they do it like this. No, in fact, we need a proper report. What I mean by a proper report, let us take this example. This is a urinary sediment report from a patient where pH was 6, density 1006, hemoglobin 3+, leukocyte esterase 3+, erythrocytes 1 to 3 only, leukocyte 1 to 2 only. So here there is a big question. Why here we do have this discrepancy between the microscope, because this is a microscope, we do have in the dipstick. In dipstick, we do have 3+ hemoglobin, 3+ leukocyte esterase, but when it comes to microscope, we have only almost normal, because below 3 erythrocyte and 1 to 2 leukocyte. Look at the lab doctor, what did he comment? He commented the following, as you can read. I'm sorry, because maybe it is too small. Mild erythrocyturia and leukocyturia. I would say there is no erythrocyturia because 1 to 3 is almost normal. Please note the discrepancy between dipsticks for hemoglobin and leukocyte esterase and microscopy. This is probably due to the cell lysis. Cell lysis caused by low density. So this low density is very important because when the density is too low, the cells will be lysed. So cell lysis will follow. So even if we do have initially erythrocyte, it will be lysed, and then hemoglobin will be there, but we don't see cells. And this is very important comment. And we hope that when we see urine sediment report and the lab technician or lab doctor give us this comment, this will help us a lot. This is another report, which is about a patient with persistent isolated microscopic hematuria. Look here, the patient is having erythrocyte 6 to 12. So this is microscopic hematuria. Isomorphic already counted here, 30%, dysmorphic 70%. So they didn't reach 80%. But look here, the acanthocytes are 15%. As we said before, if acanthocyte exceeds 5%, this is enough to say that these RBCs are of glomerular origin. That's why the comment of the lab was mild to moderate erythrocyturia without other particles, because protein was negative, everything else was negative, due to presence of 15% acanthocytes. Hematuria is probably of glomerular origin. So the lab reported that although the dysmorphic cells was less than 80%, but we still think that it's probably of glomerular origin because acanthocytes was 15%. So the conclusion from this persistent isolated microscopic hematuria is that we do have good agreement between urinary red cell morphology and renal biopsy findings. What does this mean? Good agreement between red cells morphology and renal biopsy finding. It means that when we see the morphology, it may be enough not to do biopsy, not all the time, but it assists us, it helps us to know where to go. So acanthocyte, if it exceeds 5%, this is the best marker of glomerular hematuria. But unfortunately, RBC casts are rare findings. So we shouldn't wait for the cast of red cells because it is rarely found. Now, this is a good and important message for the general pediatrician. But we don't have here on the general pediatrician. But why? Because I am saying this slide is very important for at least our pediatrician here, because usually pediatrician, general pediatrics, when they see a patient with hematuria, microscopic hematuria, or even macroscopic hematuria, the first thing they do is to look for hypercalciuria. We have to know that hypercalciuria should only be considered when other diagnoses have been excluded. So this is not the first thing we do when we investigate a patient with idiopathic hypercalciuria, because hypercalciuria and hyperuricosuriia should only be considered when other diagnoses have been excluded. The patient may have glomerulonephritis, but in the same time he has hypercalciuria. So even if we find out some hypercalciuria, this doesn't mean that the hematuria is related directly to this hypercalciuria. So this is the diagnosis by exclusion. Now, how to approach hematuria clinically? Look here, there are many things that we have to consider when we talk about clinically based approach of hematuria. But look what I have written down here: physical examination, rarely useful. But this, of course, doesn't mean that we don't have to examine the patient. We have always to examine our patients. If the patient is having generalized symptoms like fever, lethargy, abdominal pain, symptoms of urinary tract infection, everything can give us some diagnosis. For example, UTI specific symptoms will take us toward UTI as a diagnosis. Colic loin pain, calculus. History of sore throat, we may think of acute post-streptococcal glomerulonephritis. Skin rash, it may be compatible with henoch-Schönlein purpura nephritis or SLE. Arthritis also with systemic disease. Coagulopathy, history of trauma to the back, family history of Alport syndrome, polycystic kidney. All of these are very important. We have to go through, but at the end of the day, physical examination is rarely useful. Most of the time, physical examination, when we approach a child with hematuria, is normal. Now, moving to macroscopic hematuria, which is uncommon compared to microscopic. Microscopic, of course, is much more common. Macroscopic is uncommon. And you have to keep in mind that urine infection accounts for the majority. So the most important cause of macroscopic hematuria is UTI. And we have to keep, we also have to keep in mind that adenovirus also sometimes it gives a clinical picture of acute hemorrhagic cystitis. Usually it persists for 24 to 48 hours, then it dissolves by itself. Some people may hurry for some invasive investigation, but usually it disappears before starting this investigation. And also some patients, they do present with exercise-induced hematuria only after exercise. the patient himself or herself can tell us that only when I do exercise or for a long time, I start urinating red urine. Renal tumors, bladder tumors, we find palpable, but they are also very rare in children. Now, this is very important study, although it is old. It is maybe published in 1977, but why it is very important? Because it is still true. The etiology of microscopic hematuria. In this study, they looked at the etiology of microscopic hematuria in 150 children. It was published in Pediatrics, 1977. Out of 150 children with macroscopic hematuria, look here, almost 75, which means 50% of them, half of these 150 children, they had urinary infection. That's the reason why we said that urinary tract infection is the most important cause of macroscopic hematuria. Everything else will come next. Then you may have so many other possibilities like perineal irritation, trauma, acute nephritis, coagulopathy, stones. Look, stones only 3 out of 150 children. Although sometimes we may think that stone could be there. Of course, could be there. The chance is very much less. Tumor and other causes, of course. But the message from this study, which was published maybe more than 40 years ago, that UTI is accounting for more than 50% of causes. Now, when the patient is having macroscopic hematuria, is definitely different from a patient with microscopic hematuria. Because macroscopic hematuria, the child or the family, usually they are very anxious and we need some urgent investigation, of course. And we need to exclude this exercise-induced hematuria because here it is somehow benign case and it doesn't require invasive investigation. We need to observe and see. And if the patient having impaired renal function or proteinuria or hypertension or any combination of these 3, so I repeat again, impaired kidney function, proteinuria, hypertension, then again we have to consult pediatric nephrologist. This is very beautiful way to investigate gross hematuria. First of all, we have to make sure how to approach gross hematuria. First of all, we have to make sure that these RBCs, the patient is having true blood or not. So by doing urine analysis, and if the patient is having, it is not RBCs, for example, it is hemoglobin or myoglobin or pigment, then we try to solve the problem. But now, if yes, the patient is having real RBCs, then the second question is that, does the patient have urinary tract infection? So if the patient is having symptoms of UTI or not. If not, we look for protein. If the patient is having protein, to consider glomerulonephritis because hematuria plus proteinuria. Or the patient doesn't have protein, then the patient is having only RBCs. Here we look at the ultrasound to see the ultrasound if it is normal or abnormal. If it is normal or abnormal, if the ultrasound is normal, then we have to consider glomerular cause. Then again, here we have to go for isolated microscopic hematuria or gross hematuria. Now, if the patient is having some ultrasound abnormality, then we have to evaluate this abnormality. Now, moving back to microscopic hematuria, most children do not have a worrying cause. So we have to keep this in mind, that most children do not have a worrying cause, microscopic hematuria. Only 30% of cases continue to have persistent isolated microscopic hematuria over 6 months. So before asking further investigations, we have to wait for 6 months. If the patient is having microscopic hematuria isolated, we have to wait 6 months. Investigation should be delayed until 6 months But if the patient is having symptoms or impaired kidney function or heavy proteinuria or hypertension, then we don't have to wait 6 months. We have to further investigate this patient right away. But when the patient doesn't have symptom, doesn't have impaired kidney function, doesn't have heavy proteinuria or hypertension, we have to wait until the patient is having this proteinuria for at least 6 months. Well, in other references, it may go up to 2 years, but at least 6 months. If it is 6 months, then we call it persistent. So persistent means more than 6 months. Isolated means only RBCs. There is no protein, there is no hypertension, there is no impaired kidney function. Now, what are the conditions that may be responsible for microscopic hematuria? Sometimes, thanks God, the case is easy or the diagnosis is readily available. For example, post-infectious glomerulonephritis, all of us, we are very familiar with this diagnosis. The patient is having hematuria, sometimes gross hematuria, sometimes acroscopic, edema, hypertension, sometimes oliguria, sometimes impaired kidney function, low C3, high ISLO, etc. Now, so it is readily available diagnosis. Also familial hematuria. The parents themselves, sometimes they will tell you that his brothers or sister, they do have some familial hematuria. Henoch-Schönlein purpura is also very easy to diagnose. SLE, renal tumors, hypercalciuria, renal tumors by ultrasound, hypercalciuria, as I said, most people will start by doing calcium in the urine, and urolithiasis by ultrasound. So all these conditions with renal involvement gives microscopic hematuria, and the diagnosis is easy, somehow easy. Now, what is the incidence of microscopic hematuria? It may go up to 4%. So it is a common issue, microscopic hematuria. But before labeling the patient as a patient of microscopic hematuria, we should have at least 3 or 4 testing, all of them with microscopic hematuria. We cannot say the patient is having just because in one single urine test, or at least 2, it's not enough to say the patient is having microscopic hematuria, because quite often when we repeat urine, we will not see RBCs. That's the reason why we have to wait until the patient is having 3 or 4 testing. And we have to keep observing the patient at least for 6 months in order to see whether it persists or not. For some other people up to 2 years. And then the investigation should be delayed after 6 months. Why we delay the investigation? In order not to do unnecessary investigation. But when we follow up those patients, we keep in mind that, first of all, we want to make sure that the patient did not develop proteinuria, and the patient didn't change the nature of hematuria. What about renal biopsy? The timing and value remain contentious. It differs between practitioners, between schools, depending on the experience. So the timing and value remain contentious, very debatable. The views of families and children must be taken into account. Of course, we have to also take into account whether the family and the child, if the child is big enough, they are enthusiastic for or not. We have to take it into consideration. But if we do it, we have to keep it in mind also that if we have do it, this may allow us to avoid unnecessary investigation later on, especially if we find out some diagnosis. If we find out the patient is having IgA nephropathy, there is no need to go for some invasive investigation like cystoscopy or imaging. So this is one of the benefits. But the message is, I don't want to say that we have to go always for renal biopsy, but I have to say that if we do it early, sometimes it helps the patient by avoiding unnecessary investigation. Family screening is also of utmost importance, because the patient sometimes may have other children at home, other siblings, they are asymptomatic, but they do have hematuria. So we have to, especially when we don't have diagnosis. When we don't have diagnosis, but the patient is having persistent isolated microscopic hematuria, we have to see the family. We have to screen the family. Family means sibling and father, mother. And we have some time to do genetic counseling. If it is a bit complicated, it's always interesting to take the opinion of genetic people. And those patients, sometimes we don't have diagnosis, final diagnosis, we need to follow up them. Maybe with follow-up, we see how the condition is being developed. If something else start to appear, like proteinuria, impaired kidney function, and the family screening, mostly it is important when it comes to Alport syndrome. Alport syndrome, we have to investigate the whole family, males and females, children and adults, everything, everyone in this family. Because we will see later the spectrum of this familial hematuria between familial hematuria and thin basement membrane disease and Alport syndrome. So it's not always easy to know exactly whether the patient is having thin basement membrane disease or familial hematuria or Alport syndrome, because there are some vague border between these three diagnoses. And when we ask for biopsy, we have to be very cautious. When we advise the patient for renal biopsy for familial hematuria, we have to be very cautious because sometimes it comes negative, because either because we do it very early or we don't have facility, we don't have electron microscope. So we have to look at the merit of doing biopsy before taking the decision. Now, what are the indications for renal biopsy in children with macroscopic or microscopic hematuria? Now, first of all, regarding those with persistent microscopic hematuria, as I said before, the indication is contentious. It differs between practitioners. But when the patient is having associated systemic illness or significant proteinuria or impaired renal function or hypertension or family history of hematuria, here the patient may warrant renal biopsy. But again, we have to discuss every single detail. Now, there are certain specific causes of hematuria that need to be discussed case by case. First of all, which is the most important, the hereditary nephritis or Alport syndrome and its variants. This is inherited nephritis. That's why we call it hereditary nephritis. The cause of this Alport syndrome is ultrastructural abnormalities of the glomerular basement membrane. And we will talk about it later. There are deafness. Those patients, usually they develop deafness, sensorineural deafness, and they do have associated ocular defects. And it is X-linked dominant in 80 to 90% of familiar cases. But in 10 to 20% of cases, it is autosomal recessive. And recently they are talking about also autosomal recessive. So, but of course, there are new mutations accounting for up to 1/5. That's the reason why I would like to insist on the fact that when we send blood from the patient and the family for potential mutations accounting for familiar Alport syndrome, if we think about this disease, we have to keep in mind that especially if you are working in our area where we do have some new mutations, not published elsewhere, so novel mutations. So if you send it to some commercial lab will look only at known mutations. If so, that's the reason why here we have to send the blood for a lab where they look at the whole genome. So they will do whole genome sequencing, not only looking at known mutations. Otherwise, if our patient was having one of this a new mutation, this commercial lab will miss it for sure. Now, what are the presentation of Alport syndrome? In children, most commonly, the patient will have episodic macroscopic hematuria and persistent microscopic hematuria in between. Sometimes the patient will come just for microscopic hematuria. incidental finding. The patient maybe was investigated for possible UTI, and the doctor found microscopic hematuria. The urine was repeated again, it is there. When we do family screening, we may also diagnose Alport syndrome in sibling. So this is most commonly in children. The disease is, especially in young children, the disease is asymptomatic with sometimes episodes of microscopic hematuria. In adulthood, it's completely different because the patient for sure will have episodes of microscopic hematuria and proteinuria and deafness and hypertension and renal failure. So the patient in adulthood will have the full house, while in children, only hematuria, sometimes episodic microscopic hematuria or microscopic hematuria. But when we talk about big children or adolescents, here the picture starts to be a little bit more advanced, and the patient may start to have some impaired kidney function, some proteinuria, etc. In females, usually they do have persistent microscopic hematuria, and that's it for the rest of their life. Risk to their male children, of course it is there, but females rarely develop end-stage kidney disease due to Alport syndrome. What are the clinical and laboratory findings in Alport syndrome? First of all, persistent microscopic hematuria. This is the most important, whether it is in children or adolescents. Episodes of microscopic hematuria, proteinuria usually in older boys, not females, and older, maybe adolescents. Proteinuria may or may not be present in young boys. So if it is not there, this will not exclude the diagnosis. The patient must be kept under observation. Probably later on in his life will start having proteinuria. Heavy proteinuria at presentation can be there, but rarely. But when it is there from the beginning, this is a sign of bad prognosis. Hypertension and renal impairment could also be there, but girls, no proteinuria and rarely develop end-stage kidney disease. What about renal biopsy in Alport syndrome? If we don't have electron microscope, if we rely only on light microscope, this is a big problem and we may not have the final diagnosis. That's the reason why quite often we do not do biopsy just because we don't have electron microscope. I'm not saying that we shouldn't do biopsy. We should do biopsy in order to exclude other diagnoses and to look at the light microscope. It might give us some signs like mesangial matrix expansion, some segmental sclerosis, some interstitial foam cells and interstitial fibrosis. But of course, all these findings are not characteristic, can be found in some other diseases. But if we have the whole clinical picture, in addition to mesangial matrix expansion and segmental sclerosis, then it may also complete the picture. It may be helpful, of course, but the immunostaining is not contributory, it is completely negative. The electron microscope, this is the way to get the confirmation of the disease. What we see irregular thickening of the glomerular basement membrane. We see that this irregular thickening interposed with segment of thin and attenuated basement membrane. So basement membrane, some segments will be thickened, other segments will be thin and attenuated. The lamina densa takes the appearance of basket weave. Sometimes diagnosis is not easy. Why? Because the basement membrane abnormality may be subtle and confined to a short segment of the basement membrane. Sometimes, unfortunately, the specimen of the biopsy that we have taken didn't show these basement membrane abnormalities. We have also to consider some fact that ischemia also can result in the same basement membrane abnormalities. So this basement membrane abnormalities we are talking about in Alport, it is not pathognomonic for Alport. It can be seen after ischemia. The last point is, especially after kidney transplantation, you know, sometimes those patients, when we transplant them normal kidney means normal glomerular basement membrane. So the immune system of the patient with Alport syndrome will not recognize this normal glomerular basement membrane as a self. Therefore, they will develop antibody against this GBM. And we can see these antibodies, we call it allo antibodies, but sometimes these antibodies cannot be seen, and this also makes the diagnosis difficult. This is one of the cases that complex the diagnosis. So anyway, if the diagnosis was not confidentially made, then we have to consider biopsying some other affected individual in the family in order to have confirmed diagnosis. Now, what about familial benign hematuria? In fact, we have a spectrum of this familial hematuria. The most benign one is familial benign hematuria. The most risky one is Alport syndrome, and in between we have thin basement membrane glomerulopathy. So familial benign hematuria is familial by its name, no significant proteinuria, no hearing defect. It is incidental finding because the patient is completely asymptomatic, usually microscopic and persistent, and it is inherited because familial. The pattern of inheritance is autosomal dominant inheritance. So it is autosomal dominant. It is not like Alport X-linked. And if we do a light microscope, electron microscope, and immune staining, no abnormality. So the biopsy is normal. And the prognosis is good. The patient continued to have microscopic hematuria for life, but the patient will not deteriorate. That's why we say the good prognosis. What to do? It's not always sure when we make the diagnosis of familial benign hematuria. We are not always sure that the patient is really having familial benign hematuria, because we may find out later on that the patient is moving toward other diagnosis, especially thin basement membrane, because there are certain similarity between these two diseases. So that's why the diagnosis of familial benign hematuria is made with caution, because we may change mind later on. So affected individuals should be followed out throughout childhood to monitor blood pressure and proteinuria. The patient may develop later on high blood pressure and proteinuria and maybe impaired kidney function. But if it is like this, then the patient was, from the beginning, was not having familial benign hematuria. It was maybe thin basement membrane disease. So the follow-up alone and itself will tell us the whole story later on. What about thin basement membrane nephropathy, which is, as I said before, in between the familial benign hematuria and Alport? It is a common finding in familial benign hematuria. So some patient with familial benign hematuria, we may find out some thin basement membrane. And also we may find it in non-familial hematuria. Some patients will don't have familial hematuria, but they do have thin basement membrane nephropathy. The course is variable. It is not like Alport syndrome, nor like familial benign hematuria. The course is variable. It may be stable, it may worsen, it may be like familial benign hematuria. Mostly no renal failure and no significant proteinuria. Mostly, not always. If we do genetic testing, we may find out this mutation of collagen 4, A4, and when we do electron microscope assessment, we see thin basement membrane nephropathy. So it is, it could be also this thin basement membrane nephropathy, a part of autosomal recessive Alport syndrome. So when we talk about Alport syndrome, we said that in 80 to 90% of cases, they are inherited by X-linked. But in 10 to 20%, it could be autosomal dominant. But sometimes it could be autosomal recessive. If it is autosomal recessive, then the patient may manifest his disease like thin basement membrane nephropathy. I mean, may manifest his disease in slight presentation, not that much important like Alport syndrome. So some individual with familial benign hematuria may be heterozygotes for autosomal recessive Alport syndrome. So as you can see, there are some similarities between these two categories of diseases, familial benign hematuria and thin basement membrane disease and Alport syndrome. Here you can see that in this picture that there is one segment of the glomerular basement membrane here which is thin. The rest of glomerular basement membrane is normal. Only here it is thin. This is what we see here in the thin basement membrane disease. But this thing can be also seen in autosomal dominant benign familial hematuria. Here we can summarize what I have said regarding this spectrum of presentation with familial hematuria. The most benign part is this part, which is benign familial hematuria, the biopsy either normal or with some mild hilar vasculopathy. Now, if we move toward the thin basement membrane, well, here things are a bit different because when we do biopsy and we look at the basement membrane, we see thin basement membrane nephropathy, and we may find out sometimes that those patients who are diagnosed with thin membrane disease, they are mild form of Alport syndrome, especially those with autosomal recessive Alport syndrome, or some aggressive form of patients with benign familial hematuria. I mean those who were diagnosed initially as familial benign hematuria, but later on, when we did biopsy them, we noticed that they do have thin basement membrane, so we are categorized as thin basement membrane disease. Now moving to IgA nephropathy, which is common at all ages, but most common during the second and third decades. Male predominance, and rarely we may find some familial cases, but usually we don't see familial cases. Now, it is very important to understand and to know that the incidence of IgA nephropathy differs a lot between regions. For example, if we look at Asia, Japan, Australia, and some European countries like France, Italy, we see here that IgA nephropathy alone accounting up to 40% of all glomerulonephritis. So it is the most important cause of glomerulonephritis in those countries. But if you go to states or to certain European countries, like UK, for example, you see here that the IgA nephropathy accounting for 2 to 10% only of all glomerulonephritis. So there are lots of difference in terms of incidence. Why? We don't know why. Maybe there are some racial factors or some environmental factors, but for sure, the rates of urine testing and renal biopsy differs between this country. And if we practice differently, we will have definitely some different incidence of certain diseases like IgA nephropathy. Now, what are the clinical presentations of IgA nephropathy? First of all, and the most important one is macroscopic hematuria, but sometimes asymptomatic microscopic hematuria and proteinuria. Sometimes the patient may present with acute glomerulonephritis, or I have several patients with nephrotic syndrome. Later on, we came to know that they are IgA nephropathy, but presenting as nephrotic syndrome. And sometimes the patient may present with mixed nephritic and nephrotic syndrome. Now, macroscopic hematuria is the most common mode of presentation, usually precipitated by intercurrent viral upper respiratory tract infection. The onset is only 1 to 2 days. Sometimes in the same day, the patient starts in the morning coughing with high fever, and in the afternoon starts urinating blood in the same day. This is very important to know this onset after URTI, because we always compare it with acute post-streptococcal glomerulonephritis, because here we do have 2-week interval between the URTI and the nephritis. So the majority have recurrent macroscopic hematuria with persistent microscopic hematuria in between. So the hematuria will not subside completely after the attack of macroscopic hematuria, and this is very important. Now, clinical presentation of IgA nephropathy could be sometimes, as I said, as nephritic syndrome or nephrotic syndrome, or pure nephrotic, or sometimes rapidly progressive glomerulonephritis. So nephritic syndrome is the most severe glomerular damage. Hypertension and renal impairment are common, but pure nephrotic is uncommon, and usually they present as steroid-sensitive nephrotic syndrome. And when we taper off steroid, the patient may relapse, and we keep treating this patient as really having idiopathic nephrotic syndrome. But later on, if the patient need to be biopsied because he changed his presentation, we discovered that the patient was having initially, from the beginning, IgA nephropathy. Rapidly progressive glomerulonephritis can occur, but very rarely. Now, diagnosis depends on the presence of IgA deposits in the glomerular mesangium. Plasma IgA could be elevated, but only in less than 20% of children. So renal biopsy is essential. The clinical features are not diagnostic. We shouldn't rely on clinical parameters. We have to exclude, of course, other diagnosis by looking at complement levels, ASLO, ANA. Now, the recurrent attack of macroscopic hematuria is something characteristic of IgA nephropathy. So the hematuria pattern matters a lot. So the patient is having recurrent attacks of gross hematuria preceded by URTI. The onset is only 1 to 2 days compared to 2 weeks in post-streptococcal glomerulonephritis. The biopsy here, the result differs between the cases. If we biopsy mild case, then here, by light microscope, the biopsy could be almost normal sometime, or sometime with minimal mesangial proliferation. But if we biopsy the patient while the patient is having active disease, here we have a chance to see mesangial cell proliferation. But if we do the biopsy late in the course of the disease, at that time, we see less mesangial cell proliferation and much more expansion of the mesangial matrix. So here we see more mesangial matrix than cells proliferation. But we have to know that deposits of IgA is not characteristic of IgA nephropathy alone. It can be there in so many other diseases, especially HSP, Hershon-Lyon purpura nephritis, SLE, and certain systemic diseases like cystic fibrosis, celiac disease, liver disease, etc. This is the immunohistochemical staining and IF in IgA nephropathy. Now, quite often we need to distinguish between IgA nephropathy and HSP nephritis because there are certain histological similarities, and the pathogenesis of these two diseases, there are some close link. However, they are clinically distinct. IgA nephropathy usually affect older children, adults, and males, and the course is usually chronic. In the opposite, Hershon-Lyon purpura nephritis affect young children. There is no gender predominance, and most of the time it is of acute glomerulonephritis. There is no chronic course. Now, what is the prognosis of IgA nephropathy? In children, the prognosis is better than adults. Young children and those without macroscopic hematuria have the best long-term outcome. But when we have heavy proteinuria at onset, this may indicate poor prognosis. What are the signs of poor outcome? First of all, sclerosed glomeruli, crescents, capsular adhesions, and tubulointerstitial inflammation or fibrosis. All these histologic findings are carrying poor outcome. Now, moving to acute post-streptococcal glomerulonephritis, the gross hematuria persists for almost 2 weeks along with oliguria and azotemia. Hypertension may persist for up to 4 weeks, and low complement up to 2 months and sometimes 3 months. But after that, it will become normal again. And this is very important to wait until it is normal, because otherwise, maybe we are dealing with some different disease, and maybe we have to biopsy the patient, etc. Proteinuria up to 6 months, microscopic hematuria up to 1 year, and sometimes more than 1 year. So we don't have to worry, and we have to always clearly explain to the family that the hematuria will persist for a very long time. Intermittent or orthostatic proteinuria, intermittent for up to 2 years. So the patient, the disease itself, we call it short hit. The disease happened in few hours. That's it, in 24 hours, and then the patient will suffer from the consequences of this short hit disease up to 2 years here, as you can see. Now, the hypocomplementemic pattern of acute post-streptococcal glomerulonephritis is very important to know how to handle, because there are, as you know, certain other diseases where the C3 is also depressed. So for acute post-streptococcal glomerulonephritis, the C3 is universally depressed. C4 usually normal, usually, but not always. So this pattern distinguishes acute post-streptococcal glomerulonephritis from other types of hypocomplementemic glomerulonephritis, where C3 level are persistently depressed. So in these other types of glomerulonephritis, C3 will continue to be depressed, like bacterial endocarditis, SLE, shunt nephritis, idiopathic membranoproliferative glomerulonephritis. That's the reason why we have to insist on this important information that we need to monitor C3 level 2 to 3 months after the onset of acute post-streptococcal glomerulonephritis. If it remains depressed, then we have to consider other diagnoses. Now, this is how to approach a child with acute glomerulonephritis in terms of C3 level. If it is normal C3 level, so we are not dealing with hypocomplementemic glomerulonephritis. So either it is nephritis alone, like IgA nephropathy, Alport syndrome, renal vasculitis, or anti-GBM nephritis, or with multisystem disease like Wegener, Goodpasture, Henoch-Schönlein purpura. But if it is low, then we have to look at C4. If it is C4 is not low, normal, then we are dealing with acute post-streptococcal glomerulonephritis. Otherwise, if it is low also, then we are dealing with SLE. But there are some other cases where it can be mixed, like all other hypocomplementemic forms of glomerulonephritis, like MPGN, shunt nephritis, infective endocarditis, hepatitis B and C nephritis, HIV, and post-infectious non-acute post-streptococcal glomerulonephritis. You are all familiar with these hump-shaped deposits, which are electron-dense deposits characteristically, but not solely in the subepithelial aspect of the capillary walls in the form of large gumdrops. So it is not it's not pathognomonic. It can be seen in some other diseases, but usually it is there when we do electron microscopy for those patients with acute post-streptococcal glomerulonephritis. And immunofluorescence is very characteristic also, because we see these deposits of IgG and C3 in different pattern, like a grand-like or mesangial or starry sky pattern. Now, the presenting clinical features of pediatric glomerular disease that may mimic acute post-streptococcal glomerulonephritis include several diseases, which are all important and some of them common, like acute post-streptococcal glomerulonephritis, Henoch-Schönlein purpura, IgA nephropathy, membranoproliferative glomerulonephritis, SLE, and ANCA-positive vasculitis. You see here in red color, all of these patients, they may have gross hematuria, but in different percent. For example, in IgA nephropathy, it may go up to 80%, while in SLE, it is less than 10%. There are other important issues here: the age, the history of infection, the nephrotic syndrome, the C3, C4, and the diagnosis. Serology. Serology is very important, especially when it is about SLE or ANCA-positive vasculitis and the extrarenal disease, especially for systemic SLE and ANCA-positive vasculitis. Now, the take-home message is, first of all, we need a proper reporting from the lab. So we need a good lab. Second, clinically guided approach. We have to look at the clinical part, not only looking at the lab results. Family screening is especially very important in certain diseases, as I explained. UTI is the most common cause of gross hematuria. Persistent isolated microscopic hematuria cause is often not worrying. Not most of the time, the cause is not worrying. So we have to make the family very calm. Hematuria pattern is very important, like for example, recurrent microscopic hematuria in IgA nephropathy, etc. Hypocomplementemic pattern to distinguish between post-streptococcal glomerulonephritis and other hypocomplementemic glomerulonephritis. If proteinuria is there, or high blood pressure, or low GFR, then we have to seek an early consultation with pediatric nephrologist. I have a case presentation that I spoke about before we starting this presentation, because it is very important to know how to approach certain complicated case of hematuria. This is Bayan. Bayan is 11-year-old female. The chief complaint was gross hematuria since 4 years, blackish urine in the morning. Since 4 years, can you imagine? 4 years. So since she was 7 years old. Clinically stable, very stable, vital signs stable, normal blood pressure, and normal clinical examination. We did lots of lab investigation. Urine, always more than 500 per high power of film. The rest is normal. There is nothing else. No protein, nothing. Dysmorphic RBC is only 30%. So dysmorphic, so it is not of renal origin, not of glomerular origin. ESR 8/22, CRP negative, lipid profile normal, 24-hour protein is a bit high, 264, little bit high. Albumin normal, urea normal, creatinine normal, C3 normal, IgA in the serum normal, uric acid normal, coagulation profile normal, ASLO 700, hemoglobin 10.6, platelet normal, WBC normal, ANA negative, anti-DNA negative, creatinine clearance 96. So the only thing that the patient was having macroscopic hematuria, dysmorphic RBC is only 30%, no proteinuria, and nothing else. Imaging studies, renal ultrasound normal, IVP normal, MCUG normal, CT abdomen normal, and we did also renal arteriography, looking for some vascular anomaly of the kidney, normal. I don't want to go into details, but this is the imaging. As you see, the bladder is normal. This is IVP. This is the CT. This is the KUB. All are normal. And this is the renal angiography, normal. We did cystoscopy. Cystoscopy, normal appearance of the urethra and the bladder. Nothing is there. The patient still having blackish urine every morning. We did biopsy her. It did show mild focal mesangial proliferation, mild. IgA deposits are negative, and there are some mild IgM deposits. So because of this mild focal mesangial proliferation and mild IgM deposits, we have nothing else, in fact. We have nothing else, but the patient is still symptomatic. So we did say, why don't we give her a trial of steroid therapy for 1 month, full dose, 2 milligram per kilogram per day. At the end of 1 month of full dose of steroid therapy, there wasn't even a minimal improvement of pattern of density of the hematuria. So we tapered off steroid. She didn't improve at all. So we stopped steroid therapy. But what we did, we re-cystoscopy early in the morning while the patient, it was a good idea from our urologist. He advised to repeat cystoscopy while the patient having gross hematuria, because the patient is not having proteinuria 24 hours a day. Especially in the morning, the patient was having blackish urine. But over the time, when the day hours progress, the patient will have normal urine appearance sometime in the afternoon once or twice, sometime nothing, but next morning, black urine. So we undertake recystoscopy early in the morning while the patient was having gross hematuria. Reddish urine was coming out the left urethral orifice into the bladder from the left side. Clear urine was dropping down from the right side. So at that time, we realized that it is about left-sided problem, not systemic disease, because the blood was coming only from the left kidney. So we did left ureteroscopy in the same time. The urethral mucosa appeared normal. The ureteroscope could only reach the ureteroscopic pelvic junction. The dropping urine was still bloody. So the urine is not coming from the ureter, it's coming from the kidney itself. So pielocallicele origin. And we did in the same time retrograde left ureterography. This is what we see. What we notice here that this upper pole was not showing good filling. This is the only thing. So what we did coil embolization, endovascular coil embolization in the apical branch of left renal artery. Left renal artery. So left apical branch of renal artery coiling and thrombosis. Post-coiling evolution, not a single episode of hematuria, whether it is macroscopic or microscopic. When we do test urine for this patient, it does not contain any RBCs for the next 3 years, because this happened, this coiling 3 years ago. So for the last 3 years, the patient is having normal urine, no hematuria at all. So the problem was solved, hopefully. Thank you very much. So now I'm sorry if I have taken lots of time. I'm ready for the question.
Thank you very much, Dr. Professor Bassam, for this nice, comprehensive lecture. In fact, I have a few comments, if you allow me, and 1 or 2 questions. I think there is a lot of investigations regarding hematuria. There is a long list of investigations, a long list of differential diagnoses. I think one should stress on detailed history so as to direct our investigations the right direction. Detailed history will usually make our patient avoid unnecessary bothering investigations like radiological investigation or radioisotope investigations. So I think detailed history is very important. And the second point in the history, which is very important, which might solve the problem, the nature of hematuria during micturition. And this is very important because hematuria all through investigation, as we all know, that it may refer to glomerular origin, while initial hematuria refers to anterior urethritis. Terminal hematuria usually refers to posterior urethra or the bladder. The second point I want to say about it is the investigation. As you said, more than one urine exam is very important. It is not only to detect hematuria, but also to look for protein in urine. Usually, protein in urea does not exceed 2 pluses in non-glomerular origin. It does not exceed 2 pluses in non-glomerular origin, but in glomerular origin, sometimes it's 2 pluses or more. And sometimes we can detect glomerular hematuria. I don't know whether some labs do this investigation or not. We look at the mean corpuscular volume of the RBCs. Usually, the mean corpuscular volume of urinary RBC are low in comparison to the blood mean corpuscular volume. And sometimes some labs we do a urinary mean corpuscular volume divided by blood mean corpuscular volume, and if the ratio is less than 1, usually this goes more with the glomerular form of hematuria. these points I want to only mention about the history and lab investigation. I have one question regarding Alport syndrome. We know Alport syndrome is excellent recessive in 80% of patients, and sometimes in a very early stage, we find the same finding between which is attenuated basement membrane in both Alport syndrome and thin basement membrane glomerulopathy. How do you think we can solve this problem?
It's not easy to solve the problem, Dr. Ammar, between milder form of Alport syndrome and thin basement membrane disease. Especially if we do a genetic screening and we find out some collagen 4 abnormality, the known mutation for Alport syndrome, this may push us toward Alport syndrome, but unfortunately, it's not always easy to find out the genetic lab that can do it, especially in our area. The second, some of this also depend on the inheritance pattern. So some of the thin basement membrane disease, they can also be part of milder form of Alport syndrome, especially those with autosomal recessive Alport syndrome. They do present with milder form. So it's not always easy. And I would say that probably it's not always necessary to confirm the diagnosis. Maybe confirming the diagnosis between thin basement membrane or Alport syndrome, sometimes it need time. It need time to see whether the patient will develop deafness or ocular defects, or the patient will develop
family history and time.
Then the progression of the disease will be helpful also.
Yes.
Ustad Bassam, I want just to comment on something that's probably related to our work, Ustad Bassam. One of the differential diagnoses of acute kidney injury, Ustad Bassam, in IgA nephropathy is iron pigment-induced tubular damage. And sometimes we have seen patients without crescentic GN, without anything, that episodes of gross hematuria may precipitate an acute kidney injury. I will translate this into the adult practice. Persistent hematuria is one of the frequent consultations to the adult nephrologist in cardiovascular surgical problems. Patients maintained on warfarin therapy, Ustad Bassam. I commonly consulted by the cardiovascular surgeons that when he replaced the mitral or the aortic valve or both of them, that the urine exam almost always in some patients showed persistent hematuria, RBCs 3 to 4 plus, with a normal PT and INR. They cannot reduce their dose of warfarin because of the prosthetic valve, and they are asking me what to do to this hematuria. So microscopic hematuria is the commonest side effect of warfarin therapy. And even if you have a children or an adult with good indications for lifelong warfarin therapy, that the urine exam will show to you 2 to 3 plus continuously, continuously, with a normal PT-INR. And that's what faced a problem in the management of those patients. So the term arised of anticoagulant-induced nephropathy. Hematuria, persistent, complicating warfarin therapy, is a very common problem now in adults. And all my colleagues should pay attention for that. So there is a very good entity, very good lectures, very good observations that warfarin, persistent hematuria, may cause an acute and probably a chronic kidney damage on a chronic base. So even sometimes what's called hematuria that's persistent, even if the origin of the hematuria is benign for the glomerulus, it will not be benign for the tubules. And that's my opinion. Sometimes hematuria induced by drugs, for example, systemic disease, the treating physician, nephrologist, pediatrician will control the initial disease, but the persistent hematuria may get a big problem for the tubules if these tubules are exposed to a good amount of urine over months, years. The recent term of anticoagulant or hematuria-associated nephropathy, we shouldn't think of that, and probably we will face many chronic problems in the future of this persistent hematuria. I have been diagnosed the case, Ustad Bassam, متعالج سنة ال 94 على بلاستيك أنيميا في بغداد. Okay, Ustad Bassam. I faced this patient with acute kidney injury, and I was struggling. What was the cause? There was no history of non-steroidal anti-inflammatory drug induced. There was nothing in the history that gave me a hint to my diagnosis. I've done a biopsy for this patient, and it was classical pigment hemoglobin in the tubules. And after that, there was a hint in the history, as Dr. Ammar said. He told me that they give me a drug that was given by a syringe. It was cyclosporine for his aplastic anemia before 10 years. And all we know that aplastic anemia may be converted in 20% of cases into paroxysmal nocturnal hemoglobinuria. And finally, we diagnosed the case as paroxysmal nocturnal hemoglobinuria induced severe hemolysis, inducing an acute kidney damage. Although it is rare, but I think, sir, that benign familial hematuria, as you said, should be kept in mind, and some cases, probably a collagenopathy in the kidneys may appear in the biopsy or the genetic analysis, but in adult practice, drugs causing anticoagulants causing persistent hematuria may cause a chronic kidney damage, and this should be put in mind in the recent practice, Ustad Bassam.
Thank you very much. Thank you. Very, very, very useful information about those who are taking anticoagulant. In pediatric, we don't have experience with those patients because we rarely have patients who are treated with anticoagulant. But I fully agree with you when you said that this persistent gross hematuria in those patients who are taking anticoagulant, they may develop sort of acute tubular injury, and this acute tubular injury may also leave behind some chronic damage, and patient may go with chronic kidney disease related to this toxic effect of the RBCs on the tubular cells.
Iron, Ustad Bassam, is toxic to everywhere. Iron is one of the substrates for free radical production, and iron is a substitute for oxidant injury to many organs. Iron is needed by most of the free radical induced damage. Iron is a substrate. For that reason, sometimes even in CKD patients who are on hemodialysis with over iron therapy, we have a poor results even for the mortality of those patients, Ustad Bassam.
Okay.
Thank you. This was my comment because we are seeing many patients now with the hematuria persistent, and the cardiovascular surgeons are consulting us for that, and there is no definite answer to this consultation. I don't know how to answer them really, because the PT-INR should not be below 3.5 in those patients with a metallic valve, for example. And we are closely following up the kidney function tests, and that's all. We are answering that the patient needs only follow-up and not more than that.
I think this issue needs to be further discussed in meetings or in any.
Yes, we will try, sir, with you. حنخبرك أستاذ. I will try with Ala and my colleagues in the scientific committee to make a good lecture on anticoagulant-induced nephropathy. What are the literatures and what are the recent talks about that? Inshallah, Ustad Bassam. Inshallah.
Excellent topic. Excellent topic.
Thank you, sir. Thank you. أستاذ بسام, don't forget that احنا ما حنعوفك. انت حترجع تعطينا محاضرة أخرى بالمستقبل القريب إن شاء الله. أوكي أستاذ بسام.
من دواعي شرفي واعتزازي وفخري أن أحل عليكم ضيف أستاذ صفاء. هذا فخر وشرف لي. I will be more than happy every time you call me.
الله يسلمك أستاذ بسام. عيني دكتور عمار, دكتور علاء, any another questions for أستاذ بسام? عمار, علاء.
They have to unmute themselves.
Yes. بلند, دكتور بلند.
نعم.
اكو questions for أستاذ بسام يعني من الاودينس من
بالشات بوكس ماكو كويشن. واتصور دكتور علاء اكو مشكله بالانترنت, ما بقى يعني اونلاين. هسه دخل دكتور علاء
اونلاين طبعا.
دكتور علاء.
استاذ علاء, دكتور علاء تفضل حبيبي. اكو عندك اي كومنتس او اسئله للدكتور بسام على مود مني؟ على كل صار ساعة ونص, يمكن ازعجنا استاذ بسام اليوم. ثانك يو.
الله يسامحك. بالعكس I was extremely happy.
لا استاذ بسام, تعرف انت احنا I know you since I was a student in the board. I met you before for more than 10 years. من تعرفت على حضرتك وانا اعرف هذا, بس انا اريد من عندك محاضرة استاذ بسام على how the kidneys handle the acid, the kidneys, how to handle the acid, the proximal, the distal tubule, and that you can proceed after that for giving an outlines on renal tubular acidosis, just to be heard from our students from you. لأنه أنا سامعها من حضرتك, أعتقد كنت طالب بوقت أستاذ بسام بالجمعية الأردنية إذا تتذكر في بداياتها, تعرفت على حضرتك. فأريد هاي المحاضرة لأنه ما ناسيها, أريد
حاضرين.
اي والله استاذ بسام, اريد تعطيهم outline how the proximal, how the distal can handle the acid excess, and how to approach a patients with renal tubular acidosis. استاذ بسام, اكون شاكر لك اذا حضرت لنا اياها المحاضره هاي.
باذن الله تعالى. I'm ready ان شاء الله.
اي, ومن تكون حاضره ان شاء الله you can take your time 1 hour at any time. انا اريد بس الطلاب يستفادون من حضرتك, لانه الطريقه اللي شرحتها بوقتها انا كنت حاضرها. It was a very nice going to the brain right away, practical points, how to approach an RTA patient and what to be done exactly, والgenetic tests that should be done. حكون ممنون ان شاء الله اذا تكون حضرنا هالمحاضره استاذ بسام.
بكل سرور ان شاء الله.
ممنون استاذ بسام, شكرا جزيلا بروفيسور بسام. احنا اليوم فخورين كلش انه سمعنا حضرتك, والطلاب كلهم فخورين, والاطباء والزملاء كلهم فخورين. انت لو شايف الشات, many doctors has been sent to you, many thanks to you, and thanks a lot for you استاذ بسام. Thank you a lot.
شرف لي, وشكرا جزيلا مرة ثانية على الدعوة الكريمة, وكل مرة بتدعوني أنا هذا الشيء يبعث فيني كل الفخر والسرور, وانبسطت كثير اليوم معكم. وإن شاء الله دائما هيك تكون الرسائل اللي بنحكيها توصل للجميع ويكون فائدة مشتركة للجميع.
حيا الله سوريا وحيا الله أستاذ بسام, شكرا جزيلا.
هلا بيك.
شكرا جزيلا أستاذ بسام, ونشكرك باسم الجمعية العراقية لأمراض زرع الكلى. ألف شكر أستاذ بسام. شكرا.
عمار, شكرا جزيلا استاذ عمار, شكرا جزيلا حبيبي المودريتر اليوم. ثانك يو دكتور عمار. ثانك يو.
شكرا. انا اسف انقطع النت ورجع هسه. شكرا جزيلا, الف شكر. ممنون.
يا هلا بيك
استاذ بسام, ونشكرك على يعني تلبيتك للدعوه, ونشكرك باسم الجمعيه اكيد, وجميع الزملاء يشكروك هنا على الشات, وممنونين منك. وان شاء الله لقاءات اخرى قريبا ان شاء الله.
انا لازم اتشكركم.
شكرا جزيلا استاذ بسام.
يا هلا بيك.
ثانك يو. باي استاذ.